This recording will discuss malnutrition. Protein energy malnutrition, known as PEM, also known as protein calorie malnutrition, PCM, may present in three forms. The first form is marasmus. Marasmus is a calorie malnutrition in which body fat and protein are wasted. Serum proteins are often preserved. The second type is kwashiorkor. Kwashiorkor is a lack of protein quantity and quality in the presence of adequate calories. Body weight is more normal and serum proteins are low. Then finally, marasmic kwashiorkor, a combined protein and energy malnutrition. This problem often presents clinically when metabolic stress is imposed on a chronically starved patient. The outcome of unrecognized or untreated PEM is often dysfunction or disability and increased morbidity and mortality. Malnutrition is a multi-nutrient problem because foods that are good sources of calories and proteins are also good sources of other nutrients. In the malnourished patient, many problems may be identified. These problems include protein catabolism that exceeds protein intake and synthesis, negative nitrogen balance, weight loss, decreased muscle mass, weakness, decrease in serum proteins as protein synthesis in the liver decreases, vital capacity reduced as a result of respiratory muscle atrophy, diminished cardiac output, malabsorption because of atrophy of GI mucosa and the loss of intestinal villi. Common complications of severe malnutrition in adults include leanness and cachexia, which is muscle wasting with prolonged malnutrition, decreased activity tolerance, lethargy, intolerance to cold, edema, dry flaking skin, and various types of dermatitis, poor wound healing, infection, particularly post-op and sepsis, and possible death. Malnutrition results from inadequate nutrient intake, increased nutrient losses, and increased nutrient requirements. Inadequate nutrient intake can be linked to poverty, lack of education, substance abuse, decreased appetite, vomiting, decline in functional ability to eat independently, infectious diseases such as TB and HIV, diseases that produce diarrhea and infections leading to anorexia, medical treatments such as chemotherapy, and catabolic processes such as prolonged immobility that increase nutrient requirements and metabolic losses. In some cases, malnutrition results when the provided meals are different from what the patient usually eats. Be sure to identify specific food preferences that the patient can eat and enjoy that are in keeping with his or her cultural practices. Please review the chart in your textbook that goes over the older adult risk assessment for malnutrition. Acute PEM may develop in patients who were adequately nourished before hospitalization but experienced starvation while in a catabolic state from infection, stress, or injury. Chronic PEM can occur in those who have cancer, end-stage kidney or liver disease, or chronic neurologic disease. Eating disorders such as anorexia nervosa and bulimia nervosa, which are seen most often in teens and young adults, also lead to malnutrition. Anorexia nervosa is a self-induced starvation resulting from a fear of fatness, even though the patient is underweight. Bulimia nervosa is characterized by episodes of binge eating in which the patient ingests a large amount of food in a short time. The binge eating is followed by some form of purging behavior, such as self-induced vomiting or excessive use of laxatives and diuretics. If not treated, death can result from starvation, infection, or suicide. 1 in 3 patients in healthcare settings is malnourished. This may be caused by inadequate intake before being hospitalized or lack of nutrition while hospitalized because of the illness or injury. When obtaining a history, review the medical history to determine the possibility of increased metabolic needs or nutrition losses, chronic disease, trauma, recent surgery of the GI tract, drug and alcohol use, and recent significant weight loss. For older adults, explore mental status changes. Note poor eyesight, diseases affecting major organs, constipation or incontinence, and slowed reactions. Review prescription and over-the-counter drugs. Functional status can best be evaluated for institutionalized patients by assessing their ADL performance. Poor nutrition is a major contributing factor to decreased functional ability. In collaboration with the dietitian, obtain information about the patient's usual daily food intake, eating behaviors, changes in appetite, and recent weight changes. Ask the patient or family member if the patient cannot communicate about usual foods eating, cultural food preferences, times of meals, and snacks. Ask about changes in eating habits as a result of illness and document any changes in appetite, taste, and weight loss. A weight loss of 5% or more in 30 days, a weight loss of 10% in 6 months, or a weight that is below ideal may indicate malnutrition. When assessing for malnutrition, assess for difficulty or pain chewing or swallowing. Unrecognized dysphagia is a common problem among nursing home residents and can cause malnutrition, dehydration, and aspiration pneumonia. Ask the patient whether any foods are avoided and why. Ask the UAP to report any choking while the patient eats. Record the occurrence of nausea, vomiting, heartburn, or any other symptoms of discomfort with eating. Ask the patient about dental health problems, including the presence of dentures. Dentures or partial plates that do not fit well interfere with food intake. Dental caries or missing teeth may also cause discomfort while eating. Assess for signs and symptoms of various nutrient deficiencies. Inspect the patient's hair, eyes, oral cavity, nails, musculoskeletal, and neurologic systems. Examine the condition of the skin, including any reddened or opened areas. Anthropometric measurements may also be obtained as described. The nurse or UAP monitors all food and fluid intake and notes any mouth pain or difficulty chewing or swallowing. A 3-day caloric intake may be collected and then calculated by the dietitian. The psychosocial history provides information about the patient's economic status, occupation, educational level, gender orientation, ethnicity, race, living and cooking arrangements, and mental status. Determine whether financial resources are adequate for providing the necessary food. If resources are inadequate, the social worker or case manager may refer the patient and family to available community services.